Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hello and welcome to the Radiology Vault. My name is Remy Lobo. I'm on the Neuroradiology faculty here at the University of Michigan. The talk today is going to be on posterior skull base, specifically the jugular foramen, and we're going to focus on cranial nerves 9 through 11 and a little bit of 12 as well. And we'll talk about normal anatomy as well as some differential diagnoses that you can work through as you're looking at cases. I don't have any disclosures. So as every radiology talk has an outline, this one does too. We'll talk about the imaging techniques and goals and normal anatomy, both on CT and MR. And this is kind of the foundation. If you know what you're supposed to see, then you can figure out what you're looking at. I'll do a differential diagnosis review for you and focus on a few benign tumors of the jugular foramen and ways to distinguish which one you're looking at. This example case here on your right. So interestingly, when you look at the posterior skull base, we actually use MRI before we use CT, and that's because of its added soft tissue and analysis ability to distinguish different soft tissues. We'd use fat saturation on our post-contrast sequences. We get axial and coronal with fat saturation, and this is different from some of the places that you may be practicing, but we think that the fat saturated post-con techniques are extremely valuable. Pre-con, no fat sat, post-con with fat sat, and we think they're very powerful and help make things easier to find, if you will, make them more obvious, I think, to the person looking. We do use MRAs and MRVs as needed for problem solving. When we do CTs, we very rarely give contrast. Really, these are bone-only CTs. And in those cases, we're looking to find surgical landmarks and help our colleagues on the otolaryngology or neurotology side figure out where to go and what structures they need to take and where neurosurgery needs to be involved and where they don't need to be involved. The bone involvement pattern is really important, and it kind of helps differentiate which lesions you're looking at. We like to have both an MRI with contrast and with fat saturated techniques, as well as a bone CT for our colleagues before they enter the OR so they know we've given them kind of everything to look at and we've done our best to sort of help them navigate what they have to do to help the patient. Okay, so we'll look at anatomy first and look at the axial picture here. This is an axial bone CT. We're at the level of the petrous apex. You can see the jugular tubercle is also in view, right? Petrous apex, and then the jugular tubercle is also in view. At this level, we're looking at the jugular foramen, which houses two components, the pars nervosa medially, and then the pars vascularis laterally. They are separated by a little V-shaped bony structure called the jugular spine. Glomus bodies live in this area. If you know what lives in this area, you know what kind of pathology you can create. If you have glomus bodies, you can make paraganglia. You'll see those through the jugular foramen. And also you see a view of the middle ear here. So there's also glomus bodies there. Coronal, we're looking at the level of the condylar occipital bone. We can also see the temporal bone, and I'll give you a little clue as to how we're seeing that. This is the jugular tubercle that we have in view. It has this bird configuration. So bird's neck and head. Some people call it an eagle view, or some people call it, or I like to think of it as a turkey. This turkey has an eyeball, and this turkey is looking at the jugular foramen. There's also a space under the turkey's beak where the gobble would be. And that's kind of cool because in the gobble, if you imagine underneath your chin, your fingers are waggling. Your fingers waggling would be the hypoglossal nerve as it comes out. That's cranial nerve 12. So on this coronal view, you're looking at the jugular foramen where cranial nerves 9, 10, and 11 are all going to come out. And underneath it, you can actually see where the hypoglossal nerve is also going to escape the skull base. Can you see the hypoglossal nerve? You can, actually. This is a spoiled coronal postcon. And here, amidst all the venous sinusoids, is a small non-enhancing thing. And that little filling defect, if you will, is actually the hypoglossal nerve as it's exiting the skull base. Okay. When you look at kiddos, you'll see a lot of things that aren't fractures, they're synchondroses. And these are some things that you'll see as you image smaller humans as they're developing their posterior skull base. The first one is horizontally oriented at midline. That's a spheno-occipital synchondroses shown here. When you move posteriorly and laterally, you'll be able to see the petrooccipital fissure. And then at the level of the petrous apex, you also have big red. That's the horizontal or petrous segment of the internal carotid artery. Again, we're at the level of the jugular tubercle, which means we have the jugular foramen in view. And we have two components to that. Remember, there's the pars nervosa, which houses cranial nerve 9, nervosa 9, same letter. And then you also have the pars vascularis housing nerves 10 and 11. So 9 for nervosa, nervosa 9, the ends match. And then vascularis, you can remind yourself of vagus as well as 11, so 10 and 11. Don't forget they're separated by the jugular spine, that little kind of pointy bone that separates nervosa from vascularis. So here's an example case that you might come across at the workstation. This is an axial and coronal CT. Here we have a lesion. Here we have a lesion. Does it look non-aggressive or aggressive? Well, I would argue that this kind of looks aggressive. It looks like it's chewing away at bone, chomp, 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 chomp at the bone. It's centered in the jugular foramen, but it's not only in the jugular foramen. This could be picked up clinically as well. If someone looks in an ear, you can imagine an otolaryngologist looking down the barrel of the EAC. They see the tympanic membrane. They look very down low in the hypotympanum, and hey, there's something down there. They're getting a tip of the iceberg. They don't know how big this thing is, but this is the kind of thing you would see, and that might come to a temporal bone CT study. It would look something like this. So an aggressive looking lesion that's chewing away at bone that looks like it's going from the jugular foramen into the lower portions of the middle ear. An MRI, the tumor enhances. Lo and behold, tumors enhance. I know you're shocked at that. And you see some tubular shaped things internally that are not enhancing. Huh, wonder what that is. We're going to find out in a moment. So this is a case where we have a permeative destructive lesion. It's chewing away at the bone. The middle ear floor was chewed away as it worked its way from the jugular foramen into the middle ear, and it has flavoids internally. That's a glomus jugulare. That's a paraganglioma of the jugular foramen. This is another case that we're looking at. It's a patient with a left vocal cord paralysis. This is the presenting CT. Remember, for a vocal cord paralysis, we're going to image from stem to stern. We're going to look all the way from the posterior fossa and the brainstem through the aortic arch because we want to capture the course of both recurrent laryngeal nerves. This is on the left. You can see the spinnaker sail sign from the lax left-sided structures. When you get all the way up to the skull base, we find something that doesn't belong there. Here we have the internal carotid artery. Here we have the internal jugular vein, and there's a small density that's in between them. Looking more inferiorly in the carotid space, we have the internal carotid artery and the jugular vein and a small soft tissue lesion that's splaying those apart, shown there with the arrows. Take it over to MRI, and we see there's an enhancing lesion that's working its way into the carotid sheath and splaying the internal carotid artery as well as the internal jugular vein. And if we go a little bit lower, we see a central area of non-enhancing signal, almost like it's a central kind of cysticy type thing. So we have this partially cysticy thing centered in the carotid sheath that's climbing superiorly and medially towards the brainstem. So we have tubular lesion. It has a cyst internally. It's got a superior medial vector. See the way it's climbing back to the brainstem? And it doesn't have internal flavoids. Well, that's a schwannoma. So if we're looking at lesions of the jugular foramen, honestly, the most common thing we see are jugular variants. Is it a high-riding jug bulb? Is it jugular diverticulum or a diverticulum of a diverticulum? Is there some venous flow effect or catching on flare that doesn't manifest on T2 or post? Maybe it's a sinus thrombosis from some other pathology that you have going on. Less common lesions, of course, paragangliomas, dehiscent jugular bulbs, schwannomas, meningiomas, and schwannomas, etc. These are lesions adjacent to the bone. So if you have bone, you can get bone processes. Any bone lesion, you've got to think about METs. We have cartilaginous structures. We can make chondrosarcomas. Of course, as we said, METs, we're thinking of myelomas or plasmacytomas. And in younger patients, we can consider LCH as well. We're not going to talk about any of those, but just know that those are processes that can also affect this area as well. If I look at the short list, the number 1, 2, and 3 things I find here are venous effects, which we're not talking about any of these things, but this is the stuff you'd have to know when reading cases. When you're problem solving on pathology, there's the 3 down here, paraganglioma, schwannoma, meningioma, that we're going to go through in more detail. So when we think about the jugular foramen masses, we have to think about what cells live there, and then we figure out what tumors they make. So if you're making a paraganglioma, there's a parent cell. Those are the glomus bodies. So we have glomus bodies through here that can make paragangliomas. If you have schwannomas, you must have some nerves, and we do. Cranial nerves 9, 10, and 11 are all in this area, and they can make schwannomas. We have dural reflections here. Remember, there's all brain inside here with the dural reflections, and they have arachnoid cap cells. If you have arachnoid cap cells, you can make a meningioma. So we'll start with the glomus jugulare paraganglioma. As we mentioned previously, it is a permeative, destructive lesion. It is chewing through this middle ear floor. It's going to enhance on post-con MR. We're not surprised by this. On T1 and T2, you can see flavoids. It has a superior and lateral vector of spread. This lesion is working its way from the jugular foramen into the middle ear space. This is what it looks like on axial CT. You have your aggressive lesion that's chewing through the bone and working its way into the middle ear. Again, chewing through the bone and working its way into the middle ear. It's a permeative, destructive lesion. You can't use a pencil and figure out exactly how to measure this. It's kind of all over the place in there. And you can see it's even working its way all up to the level of the ossicles, right? So you can see it halfway, I mean, all the way up the tympanic membrane, almost to the scutum. So we have a permeative, destructive lesion with a superior and lateral vector of spread, superior lateral vector of spread. That's characteristic for a paraganglioma on CT. When it goes to MR, these lesions enhance, as we already mentioned, and internally you may see some non-enhancing tubes, like they're highly vascular structures enhancing. And even over here on this postcon, we even have a little bit of pepper, which isn't typical. So we had the superior lateral vector of spread of our enhancing lesion in the jugular foramen, and a little bit of pepper from the flow void from this highly vascular tumor that has a lot of vascular recruitment. So one thing to think about is the difference between a glomus jugulare and a glomus tympanicum. In a glomus tympanicum, the middle ear floor is intact. In a glomus jugulare, it's invaded. So in this case that we showed, it's a tumor of the jugular foramen that has eroded through the floor of the middle ear, through the hypotympanum, sorry, through the middle ear floor into the hypotympanum, and in this case climbs up to the mesotympanum. If this middle ear floor were intact, then the tumor would be isolated to the jugular foramen and it would never make its way in there. Now, if the tumor is isolated in the middle ear, that's a tympanicum because it will not have chewed through the floor. So if you have an isolated tumor of the middle ear that has not eroded through the floor, then you know it is a tympanicum. If you have a lesion that's doing both, going from the jugular foramen into the middle ear, then you know it's a jugulare because that vector of spread is superior and lateral. There are other locations where we can have paragangliomas that you should be aware of. Glomus vagalis are centered below the skull base along the carotid sheath. And if you have a tumor at the carotid bifurcations, we call those carotid body tumors. Those are all different versions of paragangliomas. Next example we want to go through is the schwannoma. So our first example is a schwannoma of the jugular foramen that we show here. As you can see, the beak is missing on this coronal bone CT. There's a very sharp surgical line through the temporal bone, and the beak has basically been debeaked. The beak has been smoothly remodeled. So this is a slow growing process that has kind of scalloped and remodeled the bone as it goes. These patients may present with cranial neuropathies, could be 9, 10, 11, or 12. And just because they have a neuropathy doesn't tell you what nerve is the lesion doing this. If 10's out, they'll be hoarse. If 11's out, they're going to have ipsilateral SCM and trap atrophy. If 12's out, they're going to have ipsilateral tongue atrophy and deviation of the tongue to that ipsilateral side when on forward extrusion. So what does a schwannoma look like on MRI? We've already described the central non-enhancing portion here. This is a tubular lesion. It looks like a big sausage. It's got a non-enhancing portion. That's the cyst. And note which way this thing is growing. It's growing up into the skull base and it's climbing medially towards the brainstem. So it's got an intramural cyst and it has a superior medial vector of spread. It is working its way medially towards the brainstem. It's kind of following the path of the nerve, and that's pretty characteristic for schwannomas. This is what it looks like on CT. Here's an axial CT on the left, and you can see this jugular foramen is just way too big. You can imagine that there is a process centered in the jugular foramen that has slowly remodeled and expanded and scalloped this bone. This could be from 9, could be from 10, could be from 11. You don't know which one it is till you get in there. But you know it's a non-aggressive lesion. It's got a very sharp margin to it. By contrast, so in a different location on the right side of the screen, you have a coronal CT where you have the beak view or the eagle view or the turkey view. And on the patient's left, you have a normal jugular tubercle looking at the jugular foramen and a normal hypoglossal canal. But on the right, you have a huge hypoglossal canal. And that's because there's a lesion of this hypoglossal canal that has gradually scalloped the bone and elevated the beak up as it's remodeled it. And this is an example of a schwannoma of cranial nerve 12. Moving on to the meningiomas of the jugular foramen. These have what's called a permeative sclerotic appearance on CT because they create hyperostosis in the bone. They will enhance as the other lesions, but this important distinction of these is that they do not have flow voids. That helps distinguish them from paragangliomas. The vector of spread here is what we call centrifugal. We have a lesion centered in the jugular foramen, but it can go up, it can go down, it can go medial, it can go lateral, it's going to go forward, it's going to go backwards, it's going to go every which way it can. Like all meningiomas, they can grow wherever they want. So this is an example of permeative sclerotic appearance of the bone. Here we're looking at the skull base. You can see there's not a whole lot of density in the skull base. However, when we work our way over to the jugular foramen, there's a lot more density in the bone here, and that's because this bone is reacting. This bone is changing. It's got osteoblastic activity as it turns over, creating this sclerotic appearance. Now, it's permeative because it's chomping away. This tumor is chomping away at the bone, but the bone's fighting back. There's enough bone to fight back and kind of create more bone. You can see it's asymmetrically dense in this area compared to the rest of the bone through the skull base. You can sometimes catch that on MRI as well. That's kind of the reactive change in the marrow space. So this is what they look like on CT and kind of your summary slide, your sort of take home message here. We want you to know what jugular foramen lesions look like on both CT and MR. And a really important clue is the vector of spread. So when you find a lesion, figure out which way it's going. That often tells you what that lesion is. For our paraganglioma, we look at permeative destructive lesions on CT. For our meningioma, we look at permeative sclerotic lesions where you see hyperostosis in the bone. For the schwannomas, you have these smooth, sharp, expansile margins. They're very, very sharp. Looks, almost surgical in that way. On MRI, you may catch flow voids, and you're able to detect that superior and lateral vector of spread of tumors for paragangliomas. For meningiomas, they have a centrifugal spread. They go forward, they go backward, they go medial, they go lateral, they go all over the place. And that's pretty characteristic for the meningiomas. Whereas when you look at a schwannoma, it has a very specific vector, and that vector is working itself medially towards the brainstem and as superiorly medially towards the brainstem. And that's pretty characteristic. So again, when you come to these lesions, the first thing you have to think to yourself, is this real or is this not real? Am I looking at a venous variant or am I looking at an actual pathology? And if it is one of the pathologies that we've discussed today, you should be able to distinguish between paraganglioma, meningioma, and schwannoma. Remember, paragangliomas have that permeative, destructive appearance. Meningiomas are permeative but sclerotic. And the schwannomas are smooth and sharp and expansile in their appearance. I thank you very much for your attention, and I wish you all the best in your training.